Jumping up a few levels of analysis, we're going to hear from Valerie Voon now. Valerie Voon is a Senior Principal Investigator, Neuropsychiatrist, and Medical Research Council Senior Clinical Fellow with the Department of Psychiatry at Cambridge. She has also recently started as a Distinguished Professor at Fudan University in Shanghai. She is the current President of the British Neuropsychiatry Association. The Voon Lab spans across Cambridge and Shanghai, focusing on understanding mechanisms underlying self-control and compulsivity. And the lab is currently focused on identifying modifiable biomarkers for invasive and non-invasive neuromodulation relevant to addictions and compulsive behavior. They use multiple modalities, including imaging, physiology, pharmacological challenges, cognitive neuroscience, and computational modeling approaches. So they really have quite an arsenal of techniques to investigate addiction. So please join me in welcoming Valerie Voon.
So thank you to the organizers for this invitation to speak. It is very much a pleasure to be able to talk on this topic. So I'm going to talk about addictions as a brain network disorder. I'm going to focus particularly on alcohol misuse. And we'll touch on large data studies focusing on structure and function. And at the very end, we'll very briefly touch on neuromodulation and how they might modify these neural networks. So as we know, alcohol misuse is a major international public health issue, a high common global prevalence, particularly in men, about 8% and 1.5% in women. Again, significant marked impact in 15-year-olds to 49-year-olds. It's a global leading cause of death. And in societal cost estimates within the United Kingdom, we estimated about 21 billion, which is between 1 to 3% of the GDP. So I'm going to, at the very beginning, just so that everybody's on the same page, focus on some aspects of background on the addiction cycle, addiction theories, and then particularly focus on the Addiction Neuroscience Imaging Assessment Review, ANIA. I'll just recommend that you take a look at this particular paper if you want to go a bit more in depth into what I've been discussing here. And then I'll touch on some of our some recent big data findings that have been published. Also work from my lab looking at the UK Biobank data, looking at correlation and prediction, and then we'll look at the convergence with function. So here there's a range of different cognitive processes. We'll focus on some studies looking at negative emotionality and goal-directed control. And then at the very last, I will touch on neuromodulation, but it will be just a single slide. So this particular model of the addiction cycle is very well discussed by George Koob. The idea that we start out with these binge intoxication phase, moving into this withdrawal phase, and then a more prolonged preoccupation and anticipation phase. And then you repeat this cycle with relapse behaviors. And we can, what's going on here? Then we can also map onto this addiction theoretical mechanisms, kind of the three primary ones of incentive motivation, negative emotionality, and the transition from impulsivity to compulsivity. And I'll discuss this in some detail. So this is from Brian Knutsen's review, a very nice kind of pictorial that shows the different brain regions that are implicated in disorders of addiction. So here, highlighting three main networks, the prefrontal cortex, basal ganglia, and the extended amygdala. So here in the prefrontal cortex, the ventromedial prefrontal cortex involved in representing goals to guide behaviors, the orbital frontal cortex here involved in behavioral flexibility, the dorsal cingulate more in self-control, and then not shown here, but the lateral prefrontal cortex more in executive function involved in planning and working memory. And this prefrontal cortex is part of the frontostriatal circuitry, mapping and in a organizational topography onto the basal ganglia. So here, this is the striatum, and the ventral regions map onto the ventral striatum involved in motivational processes. the caudate and the putamen more in action outcome contingencies. And then within the basal ganglia and frontostriatal circuitry, other brain regions that are relevant in addictions include the ventral pallidum and also the subthalamic nucleus. Within the extended amygdala, I'm showing here how close different certain brain regions are in terms of potential stimulation targets. So the extended amygdala consists of the amygdala involved in salience and also in terms of negative and positive affect representation. Here, the ventral striatum is shown in pink here, and it's about 2 millimeters away from the bed nucleus of the stria terminalis. So this is a structure that involves multiple subnuclei. It's the output structure of the amygdala, and it's involved in tonic representation of fear processes. So this extended amygdala is very much implicated in negative emotionality theories. Okay, so just to go over some of the underlying theories and how we might approach some of this with some of our imaging modalities. So incentive motivation theories suggests that alcohol cues develop these incentive motivational properties that can then lead towards subjective craving and relapse behaviors. And what you can do is then show alcohol images. This is a very straightforward one. Show alcohol images or other drug cue images, and this greater neural reactivity that actually has the same pattern across different substance dependence and also alcohol dependence. You see the same brain regions that are hyperactive in response to these alcohol cues or drug cues. So the ventral striatum, the cingulate, amygdala, anterinsula, and orbitofrontal cortex. You can then also look at subjective craving, and you see a similar pattern emerging across similar brain regions. And you can parse it down into underlying cognitive processes to a greater extent. So look at underlying motivational processes, a willingness to work for the alcohol, greater attentional bias drawn towards the alcohol cue, the tendency towards approaching it more, or greater autonomic reactivity. So your heart rate goes up, blood pressure, and you start to sweat more. So different kind of parcellating out of different cognitive processes underlying this incentive motivation theories. Another prominent theory is this transition from impulsivity to compulsivity. So a lot of work coming from Barry Everett's group and Trevor Robinson's group, and from my own group. So looking at the idea that impulsivity, so generally defined as being disinhibited, these rapid, poorly considered decisions despite negative consequences, they start out as a risk factor towards developing or transitioning towards starting use of alcohol and drugs. And then with excessive use of substances, you then transition towards much more greater compulsive behaviors, these repetitive, inflexible behaviors that occur despite changes in the environment and despite negative consequences. You can parcellate this out into multiple different subconstructs. So impulsivity parcellates out into different subconstructs. Compulsivity also parcellates out into different subconstructs. You can see here that the colors that I show just represent the different, how they map differently onto the frontostriatal circuitry. So again, you can take a look at some of these images, again, from that review paper. And this, the final one, looking at negative reinforcement theories, and this I'm sure will be discussed to a greater extent throughout the course of this meeting. So the idea that initially we start out with positive reinforcement, that we're taking drugs or alcohol based on the positive hedonic properties, and over time with excessive exposure, we start to be driven by negative reinforcement. So to try to avoid the stress or the comorbid anxiety and depression that occurs, or to avoid withdrawal states. And again, they can be mapped onto different substrates, particularly implicating the extended amygdala and the anterinsula. Okay, so I'll point you now towards, again, this particular review as it goes into a fair amount of detail, again, focusing on alcohol misuse and structural and functional imaging. This is just an image from this review. And here we'd looked at the multiple different forms of task-based fMRI studies. So you can take these theories, parse them out into different cognitive processes, and you can then look at and ask what underlying neural substrates may be implicated in alcohol misuse. And here we've just mapped onto the different regions in the prefrontal cortex and also within the striatum. And we've also mapped out studies in cortical thickness. Okay, so now I'm going to focus in on more recent data. So this is moving from that particular review and moving into more recent data that's been published and some that's unpublished. So this is from the Enigma Addictions Consortium. So it's a mega-analysis of gray matter volumes. And here they're looking at about 2,000 subjects, and about 900 have alcohol or alcohol dependent, 600 nicotine dependent, and a range of other substances like methamphetamine and cannabis and cocaine. And the take-home message here is that most of the decreases in brain volumes that are associated with dependence appear to be driven by alcohol dependence. Okay, so in the alcohol-dependent group, compared to the healthy controls, you see that across 26 different brain regions, you see this decrease in brain volumes that occur lateral prefrontal cortex, the medial prefrontal cortex, and also subcortical regions. Actually, you don't see that with the other disorders. So cocaine, you only see a single substrate. The temporal cortex is decreased compared to healthy controls. You don't see any differences in terms of nicotine, cannabis, or methamphetamine. And you see this visually represented here in the nucleus accumbens. This is a decrease in volume in alcohol dependence, but you don't see this in the other substances. So really emphasizing the effects of alcohol or the correlation between alcohol dependence and lower brain volumes relative to the other substances. This also similarly highlights the same findings, but now focusing more on the subcortical surface morphometry, so looking at hippocampus, the striatum, including the putamen, the nucleus accumbens, and the amygdala, and really highlighting here, again from the Enigma Consortium, that alcohol is associated with a decrease in volumes compared to healthy controls, so this is negative. But then nicotine is actually the opposite. You see this increase in these same brain volumes compared to healthy controls. Again, really emphasizing this correlation with lower volumes or subcortical surface morphometry with alcohol dependence that you don't see with other substances. You see the same thing here with a younger population. This is the Minnesota twin study. The age is 24 years. The previous one with the Enigma, the mean age was in their mid-30s. You see the same findings. So here, this decrease in brain volumes here highlighted in yellow in the lateral prefrontal cortex, the dorsomedial regions. And this is specific to alcohol use in this younger population. But cannabis, you do not see a difference in cortical thickness. Okay, so again, highlighting similar findings as previous, but in a younger population. There's also gender differences. So this is again from the Enigma Consortium. So focusing on the amygdala and the hippocampus and subdividing regions of the amygdala. And here you see in alcohol-dependent men that they have lower volumes of the amygdala, and that's specific to the basolateral nucleus. But you don't see this in women. Okay? So this is an effect that's driven, that's gender-specific, predominantly in men. And then the hippocampus, you see that there's decreased volumes across both males and females who are alcohol-dependent compared to healthy controls. Okay, so now I'm going to spend a little bit of time just talking about some of the data that we've been analyzing. So this particular study we have submitted and it's passed its first review. So this is in the UK Biobank data. So this is a normative data set in the United Kingdom involving over close to 25,000 subjects. Normative meaning that there's a range of alcohol misuse from 0 up to a higher range and a mean audit score of 5.2. It is an older population, 45 to 81 years old, so mean age of mid-60s. And what you're seeing in the middle here is the T1 gray matter volumes And here on the right, the resting state fMRI nodal degree. So these are subjects who are lying in the scanner. They're asked to just lie there with their eyes open. And we look at brain correlations between different regions. So how regions might talk to each other. And the nodal degree is just the degree of connection between different brain regions to that specific voxel. So what I'm going to highlight here is just the peak findings, the peak regions. So what you're seeing here is the greater the alcohol use in this older population, the lower the brain volumes in the dorsal cingulate and the dorsal medial prefrontal cortex, and also the lower functional connectivity in the same region. So you're seeing that both structure and function appear to be associated in the same brain region in these dorsal prefrontal cortex, in the dorsal medial prefrontal cortex, associated with alcohol use. And we then went on to look at machine learning using support vector regression, and again, similar findings highlighting this dorsal cingulate region. Okay, we then asked, how does this relate to prediction of alcohol use? So this is the same brain imaging findings, but what happens with behavior 2 years down the road? So the mean is a 2.4-year follow-up between 1 to 7 years, and it involves over 3,000 subjects. And now you're seeing a slightly different pattern emerging. So the lower the brain volumes in more ventral prefrontal cortex, so this is now the medial orbitofrontal cortex, the ventromedial prefrontal cortex, extending into the subgenual cingulate. We're also seeing it in the ventral striatum, the putamen, and also bilateral amygdala. You see this across, again, both the gray matter concentration and the nodal degree, the functional connectivity. And what we're seeing here is the lower the structure, the volumes, and the lower the connectivity in these ventral medial prefrontal regions and the limbic regions, the greater the likelihood of drinking more alcohol 2 years down the road. And so across this 3,000 population, 18% of subjects increase the amount of alcohol they use, and 18% decreased and 13% increased. So what you're seeing here then is a dissociation between what we think may be the effects of alcohol use on dorsal regions, and then perhaps what might be predictive of subsequent alcohol misuse, more in ventral and limbic regions. Okay, so now we've discussed a little bit about sort of the big data findings with structure and resting state functional connectivity. I'm going to move into a data set that focuses more on negative emotionality. And this is also from the UK Biobank. And again, this is with my postdoc, an excellent postdoc, Yang Zhao. And this is using the negative faces and shapes task, which was run and scanned within the UK Biobank data set. Very well validated task, and you're just asked, there's two different conditions, either shapes or negative affective faces, either fearful or sad faces. And you just asked, when you see these three images, which of the bottom image matches this top one? So in this case, it would be the one on the right. And then in this condition, exactly the same, the one on the right. And what this allows you to do then is look at the contrast of negative faces versus shapes. And what you'd expect to see, this increase in activity in ventral prefrontal regions, two negative affect images, and this increase in amygdala activity. So we then went on to ask, well, how does this relate to alcohol and smoking? So this is in over 21,000 subjects and the relationship with audit, and in over 26,000 subjects in the relationship with pack year. So when you show negative images, you get this decrease in prefrontal activity with greater alcohol and smoking use. Okay, so you see this decrease in blue here with prefrontal activity. The critical thing is the differences in terms of amygdala activity. So in alcohol use, the greater the alcohol use, the greater the amygdala activity to negative imagery. But in smoking, you see the opposite. So you see this decrease in activity in the amygdala to negative imagery. Okay, so then we went on to ask, well, what does this look like in terms of what might be regulating the amygdala from prefrontal cortices. And we selected 3 brain regions which had been activated in the previous study, in our previous findings. So the ventromedial prefrontal cortex, orbitofrontal cortex, and the dorsolateral prefrontal cortex. And these findings are all Bonferroni corrected using dynamic causal modeling, looking at effective connectivity. So here, to this negative affect task, if with those that drink more, so higher audit scores, we see this decrease in effective connectivity, a decrease in top-down control from the ventromedial prefrontal cortex to the right amygdala. So this may be part of the reason why we're seeing this disinhibited excessive activity of the amygdala to negative imagery with alcohol. We see a different pattern with smoking. So the more you smoke, the greater the bidirectional connectivity now between the orbitofrontal cortex and amygdala. And this bidirectional connectivity may be the reason why we're seeing this hyperactivity and lack of this decrease in activity and perhaps greater regulation of from top-down control of the amygdala with smokers. So again, this dissociation that we're seeing with prefrontal amygdala connectivity and perhaps the impact on amygdala reactivity to negative imagery as a function of smoking and alcohol. Okay, so now I'm going to just move into the last bit, which is talking about goal-directed control. And this is predicated on the very influential habit theory of addictions that comes from Barry Everett's and Trevor Robinson's work and Anthony Dickinson's, all from Cambridge. So looking at the idea of cooperating, competing systems between goal-directed and habitual systems. And just to make this very concrete, you can think about the differences between goal-directed and habit control in a very concrete way, just based on what happens when you're driving a car home. So if you're driving down the freeway and you usually have to turn right to go home, but you make a decision to move homes after 20 years and you need to turn left to go to your new home. When you're initially focused and paying attention, it's much more computationally demanding. You'll be more goal-directed. You'll take into account the final outcome, which is your new home, and use your mental representation and mental representation of the neural map to then turn left and go towards your new home. Whereas in contrast, as you become much more tired over the next several weeks with greater cognitive load from work or stress, you'll then rely more on automatic, habitual, overlearned systems. You'll then make your choices based on previously reinforced actions. You'll make a mistake and end up turning right and going back to your old home. And that's a model-free approach. And this idea of this transition between goal-directed to habitual systems underlies this habit theory of addictions and this shift from engagement from ventral to dorsal striatal systems. So I'm going to just briefly talk about some work that different groups and my group have been doing, looking at goal-directed control, and to some extent it captures some aspects of habits. So this is using the two-step task in which subjects choose between one of two stimuli at the first stage, and this is fixed transition, a fixed probability to transitioning to one of two states. You then choose one of these stimuli, and this is changing probability, then receiving a reward. I'm only going to very briefly touch on this, but you can capture using computational modeling. This is a Rescorla-Wagner reinforcement learning algorithm. And really all it's doing is capturing the idea that you're making choices based on previously reinforced actions. So it captures the concepts of habits. And in contrast, you can capture a goal-directed component. And again, the idea of this internal representation of the task structure and capturing this transition state, this fixed probability in your decision-making. And we're really interested in this arbitration between habit versus goal-directed control. And there's various different ways of measuring this using behavioral and computational models. So this is just a summary of some of the work that my group has done looking at the relationship between multiple modalities. So here looking at medial orbital frontal cortex and caudate and ventromedial prefrontal cortex, and showing that you have this increase in brain volumes associated with goal-directed control within these brain regions. You have this increase in functional connectivity and an increase in a measure of a diffusion measure of the orientation dispersion index, and also this serotonin ligand, a serotonin transporter ligand, again within the same brain region. We then go on to ask, how is this related to underlying patient populations? So binge drinkers do show a decrease in goal-directed control, but it seems to be dependent on how recent they had a binge drinking episode. So if they're only several days after the binge drinking episode, you see this decrease in goal-directed control. So suggesting that the alcohol use may have impacted the shift in goal-directed versus habitual behaviors. And then 5 days afterwards, you see this improvement in goal-directed control. In terms of alcohol dependence, you don't see any differences between alcohol dependence and healthy controls, but with abstinence, you do see an increase in goal-directed control after multiple months in abstinence. So again, really highlighting the impact of the substance on this arbitration between goal-directed and habit behaviors. There's some very nice data coming from the group in the Charité. So these are two separate studies, one in alcohol dependence, the other one in young adults. In the top here, what you're seeing is ventromedial prefrontal cortex activity to prediction error. So in this case, goal-directed state prediction error. And if you, in the alcohol dependents who have lower activity to goal-directed ventromedial prefrontal cortex prediction error activity, they appear to also be more likely to relapse several months down as compared to remaining abstinent. Okay, so it seems this ventromedial prefrontal cortex activity appears to predict relapse behaviors in alcohol dependence. And then in healthy controls, this is now in a younger population, again, the same brain region of the ventromedial prefrontal cortex, but now looking at an aspect of habit, which is a model-free prediction error. What you're seeing is that greater activity to habits in the form of reward prediction error appears to also predict greater likelihood of increasing alcohol use in young adults and within a 3-year duration. So this activity related to this underlying cognitive process of model-free versus model-based arbitration and prediction error appears to predict alcohol behaviors over months or over years. Okay, so I said that I was going to discuss a little bit about neuromodulation. Just in the interest of time, I'm going to show one slide and really just highlight that what we're doing with brain stimulation is really targeting these underlying neural networks. So you can either use deep brain stimulation, which is using high-frequency stimulation targeting specific brain regions directly, either gray or white matter, to modify underlying neural networks or physiological activity, or you can use, in this case here, TMS, which is an electromagnetic field, to non-invasively modulate underlying neural brain regions and network activity. So in green here, I show some of the target areas related to TMS. So the ventromedial prefrontal cortex from Colleen Hanlon's work, the anterior and lateral prefrontal cortex as a target in cigarette smoke, in nicotine dependence, and then some of the brain regions. Again, this is at the level of more case series rather than randomized controlled trials. The dorsal cingulate, nucleus accumbens, and ventral internal capsule as targets for addictions related to deep brain stimulation. So again, really attempting to modify the neural network that I just identified that's aberrant in disorders of addictions. Okay, so just to summarize here, so alcohol use and misuse is associated with greater gray matter impairment, and this is much more prominent relative to other substances. We seem to be able to some extent, dissociate cause and effect in the UK Biobank data focusing on both gray matter structure and resting state function. So there's greater impairments correlating with alcohol use in the dorsal medial prefrontal region, but more ventral regions, the ventral medial prefrontal cortex, ventral striatum, and amygdala, so more limbic regions, greater impairment appears to predict subsequent alcohol misuse. We've also looked at underlying cognitive function and touched on the issue of negative emotionality. So here, looking at negative affective images and showing that alcohol is associated with greater amygdala activity and smoking the opposite with lower amygdala activity. And we think it might be related to this top-down prefrontal amygdala effective connectivity, which seems to be different between alcohol and smoking behaviors. I also discussed a series of work that involving impairments in goal-directed control and their relationship with ventromedial prefrontal cortex function that's predictive of alcohol misuse. So there's a range of other cognitive processes. I just haven't discussed them specifically here. But again, these underlying mechanisms and identifying these underlying neural networks, the rationale for doing this is to start to understand what are we targeting and how are we targeting this with neuromodulation, and in terms of using neuromodulation, both invasive and non-invasive, to try to modify this pathological neural network. So this is my group. It spans across Cambridge and Shanghai, and they've been instrumental in all of these studies. I couldn't do anything without them. They've been absolutely brilliant. I do have extensive collaborations with Ruijin Hospital with Professor Bowman's son, completely different set of studies, but all involving neuromodulation. And I'm very grateful to that set of collaborators and the collaborators at Fudan University.
So we have time for questions. Back there? Yeah.
Hello, Valerie. How are you doing? Andres here. I just had a question about the UK Biobank study. So one of the issues with the UK Biobank data is that it's quite biased towards older people. And then structurally, there's a lot of other things, I mean, in terms of socioeconomic status, ethnicity, and so on. I mean, my question is mostly related to age, because when, you look at the data you presented, I think the youngest participant was about 41, if that's correct. And at 41, and if you do have a probable alcohol use disorder, the exposure has already happened. So my question is about, when you talk about prediction specifically, how can you separate something that might be actually causal rather than predictive of alcohol use, and how that worked in your study?
Yeah, so we've actually analyzed this data to include baseline alcohol use. So baseline meaning at time point 1, as a covariate of no interest to control for the effects of alcohol use on the predictive capacity. So we have taken into account exactly the question you're asking. I do agree with you, it is a very specific population, but it is an older population. Having said that, there is a middle-age drinking and alcohol misuse in middle age is a major issue also within the United Kingdom and internationally. I think there are studies underway that I'm aware of taking place with the Imogen data set, which is much younger population, and they're looking at trajectories of initiating alcohol misuse, and that'll have a different impact compared to this specific set of this specific study. But I think it's important to take into account age-related differences, and it is conceivable that you may have a very different pattern as a function of age. And I suspect that we might see something a little bit different with an earlier data set.
Hi, great talk. So I was wondering if you could talk to us a little bit more about the co-use of drugs between smokers and alcohol users in your data set. So I was particularly struck by the finding of the divergence in functional connectivity between the PFC in the amygdala in response to negative imagery. So I guess, we know in clinical populations that almost maybe 80 to 90% of people with alcohol use disorder are also smokers. So I was wondering, do you think that nicotine, alcohol, do one of these effects dominate, or do you think kind of the synergistic effects are mediated by a separate brain network?
Yeah, I think some of the effects very clearly overlap. So if you look at the cue reactivity studies, for instance, they very much overlap in terms of the same brain networks being activated, just alcohol and smoking cues. Having said that, in our data set, because the data set was large enough, we were able to control for the effects of smoking on alcohol and vice versa. So when you're looking at the initial set of correlations associated with just smoking and alcohol, that you do see very similar patterns when it comes to the correlation. So both these dorsal cingulate, dorsal medial prefrontal cortex was decreased to both smoking and alcohol, and they controlled for each, even when you control for each, so it's additive on top of that. But prediction was only seen in the alcohol. We didn't see it in the smoking effects. Okay, so we didn't see anything with smoking. With regards to the second study looking at negative affect, we did see different brain regions that seemed to be modulating differentially the amygdala. So the ventromedial prefrontal cortex was modulating the amygdala, and then for alcohol, and then orbitofrontal cortex modulating for smoking. But we controlled for both of those we controlled for the opposite. So we controlled for smoking when we were analyzing the alcohol behaviors, and we controlled for alcohol when we're analyzing the smoking behaviors. So I think that there's going to be commonalities, but critically there will be differences. And I think understanding those differences is important when you're thinking about which neural regions to target for neuromodulation.
I think there will be more questions, but I'm going to sneak in here before Bill does, because I have so many questions, and I have a rather broad one that I'd like you to speculate about, Valerie. Your last slide was really exciting to me, the stimulation slide, and particularly because so much has happened in the last 10 years with respect to developing methods, both deep brain and not deep brain, in terms of stimulating the brain, both in people and animals. And I'm just wondering if you can take your crystal ball and you have a lot of data that's coming online now, and think with us about what's going to happen in the next 10 years in terms of stimulation for these addictive disorders. Do you see this as a viable clinical path? And if so, what kinds of techniques do you think are the most viable?
Yeah, so I think, when you're thinking about disorders such as addictions or in general psychiatric disorders, as a general principle, I do think that non-invasive neuromodulation techniques are ideally the kind of optimal therapeutic method because it's non-invasive. Having said that, I do think that the surgical methods, such as deep brain stimulation, it's been shown to be effective in obsessive compulsive disorder. And there are several studies underway with regards to disorders of addictions. And a method in which remains in place and potentially could be modulated based on a closed loop feedback paradigm may actually be incredibly useful for relapsing remitting illness would be my take on this. So something that remains in place, that's switched on when you're likely to relapse, or that decreases when in remission, is probably in a way an ideal form of stimulation for a disorder such as disorders of addictions. Having said that, I think that at least for the next 5 years to 10 years, I think there's still very much a role for deep brain stimulation methods. And then as we start to develop novel, non-invasive methods that are much better at precisely targeting neural networks that are deeper, we may be able to move more towards non-invasive methods. I think even in a non-invasive domain, we're really trying to move towards more accelerated paradigms that are shorter, that are more rapid, so people don't have to come in repeatedly, because you lose a lot of people in having to come back 20 times over the course of a month. So methods that can accelerate neuromodulation and that are faster in onset, I think, are ideal. But there's certainly lots of interest in ultrasound techniques that are non-invasive, in high-density transcranial electrical stimulation techniques. So it's a really rapidly evolving field and very exciting.
Thanks. I jumped in before Bill, so I apologize, Bill.
Hi, Valerie. Just a couple of technical questions I'm interested in. First of all, do we know anything yet about what's actually happening biologically inside these voxels that reveal thinning cortex or decreases in volume? I mean, are cells being killed? Is it neurons? Is it vasculature? Is it glia? That would have to be taken apart in an animal, of course, not in a human. And then the second question, most of your alcohol use data seem to relate to binge drinking, and I just want to know what the definition of binge drinking is, and whether it's really something pulsatile about the binge that's having the negative effects, or whether it's basically the same alcohol use integrated evenly over time is also equally damaging, or is there something about the binging that's particularly damaging? So two entirely unrelated questions. Sorry.
Yes, they are very different questions. So the first one, I think the studies would mostly come from either primate studies or post-mortem studies. Again, I think a lot of even though it would be nice to be able to say actually this specific neuronal population is actually decreased in size and volume, a lot of it is the supportive cells, actually the kind of astrocytic and the glial cells that are probably being affected in terms of the changes in volume. I think that your second question with regards to changes in the differences between binge drinking and alcohol dependence, I tend to see alcohol misuse in the context of a dimensional basis. So I tend to think of binge drinkers somewhere along the spectrum of alcohol dependence. Having said that, I do think that binge drinking probably has its own specific mechanisms that might have a very different effect potentially compared to kind of chronic alcohol use. Because of this pulsatile binge drinking and the marked withdrawal states that might occur after each binge drinking episode. To some extent, we ended up looking at binge drinkers because binge drinking is quite prominent within the United Kingdom. So that was part of it, particularly in the slightly younger population. And they were actually slightly easier to recruit also. So that was part of the rationale behind why we ended up looking at binge drinkers. There was a practical aspect to it. So I think that might answer some of your questions.
Well, I'd like to thank Valerie for joining us so late at night with such a wide-ranging interview or review of the field. We really appreciate it. Thank you so much.